Good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. In this particular video, I am going to be reviewing some protocol changes or some changes to our clinical practice guidelines here at the paramedic program. So this is going to be more focused on my students. I'm sorry I wasn't able to go over these guidelines in person, and I understand that I'm recording this video during the break, so you are actually not in class. But I wanted to push this information out as quickly as possible and have it available day one for when classes begin here in about 2 weeks, a little less than 2 weeks from the recording of this video, because on day one, you will be on the ambulances, and then within a few weeks, we'll begin our first of a couple of hospital rotations. And so I do want to ensure that I'm pushing these guidelines out and I'm covering them. And I was just received an email from our medical director, Dr. Diven, that these have officially gone into play. And of course, these guidelines are the same guidelines that Las Cruces Fire Department follows because we share the same medical director. So it makes sense that our clinical practice guidelines would be the same. Just keep in mind that anything that is considered a special skill within Las Cruces Fire Department is not something that we have in our clinical practice guidelines as paramedic students. There are some differences, and we've covered them in prior classes, and you know that because you've already had one rotation of field time. So the specific changes that I'm going to be talking about are referenced in your clinical guidelines. There is a link in the welcome module in the second field rotation course in Canvas. It's the same link that we've been using to reference our clinical practice guidelines throughout the program. If you click on clinical guidelines, and specifically the medical guidelines, you will see a new module labeled Overdose Psychiatric Medications. So these are some basic guidelines to cover an increasing trend that we're seeing of individuals who are overdosing in using psychiatric medications, among others. Of course, polysubstance overdoses tend to be very common and confusing. So this is just going to take a deeper dive into specific categories of medications, and these are categories of medications we've actually already covered in our pharmacology block and in the toxicology block of medical emergencies. So there's really nothing particularly new here. This is just going to be an overview of content we've already talked about. I'm just going to talk about the CPG and just start at the beginning and work my way down, overviewing it. So overdoses, psychiatric medications. Overdoses are common. They can be intentional or non-intentional, and intentional overdoses may be a manifestation of a suicide attempt. Unintentional overdoses can be the result of confusion over taking prescription medications, misuse of recreational or illicit drugs. We see this fairly common in our older patients or patients with neurocognitive disabilities where they may not intend to harm themselves, but just due to confusion and things of that nature may end up unintentionally overdosing. So that is actually pretty common. Overdoses of psychiatric psychoactive medications pose a unique challenge. Often these overdoses involve more than one medication, i.e. polysubstance overdoses, and can confuse the presentation management of the patient. So what are some general treatment of these kinds of overdoses? The patient needs a comprehensive history, and it should be taken including all medications and a thorough physical exam. You need to attempt to search for prescription bottles and try to estimate the amount that may have been taken, all right, based on your assessment of those. How many pills, what is prescribed, and how many pills are left in those bottles. Any history of recreational or illicit drug use should be investigated as well. The patient should be evaluated with a monitor that can obtain full set of vital signs, pulse oximetry, capnography, and cardiac telemetry. Oxygen should be given if indicated. Suicide intervention should be conducted as needed. If needed, The New Mexico Poison Control Center is an excellent resource for additional information, evaluation, treatment, and monitoring of overdose patients. Remember, the phone number for poison control is 1-800-222-1222. Overdose patients should be transported to an appropriate medical facility for evaluation and treatment. Okay, so let's talk about some specific categories of psychiatric medications where we see either an increasing trend of overdoses or we have baseline where overdoses, you have a baseline commonality of overdoses of these substances. So the first category are the tricyclic antidepressants, and I've done prior videos on these. These tend to be highly toxic and they can produce serious and occasional fatal results when overdosed, particularly in very young patients and people who have underlying physiological decompensating disorders, right? Liver disease, kidney disease, cardiovascular disease, and so on and so forth. These are sometimes referred to as quote unquote one pill can kill agents. Many of the tricyclic antidepressants, among other categories of drugs, fall into this category of a quote unquote one pill can kill. Expeditious transport to an appropriate medical facility should be undertaken once the patient is prepared for treatment transport. 12-lead ECG monitoring should be obtained and frequently reassessed. Common arrhythmias associated with TCAs include a variety of findings to include AV blocks, sinus and ventricular tachycardias, prolongation of the PR interval, QRS interval, and of course it's going to cause a prolongation of the QT interval, and rarely, but occasionally, torsade de pointe. Arrhythmias that compromise patients' hemodynamic stability are a threat, such as ventricular tachycardia with a pulse, and should be treated with intravenous sodium bicarbonate, and this may need to be repeated to contain the dysrhythmia. I would also add that if you have a widened QRS complex tachycardia in the setting of a suspected tricyclic antidepressant overdose, you should also be treating that with sodium bicarbonate, because one of the lethal underlying problems is a sodium channel blockade, or a sodium channel blocker overdose in essence. They do other things as well, right? Such as they can cause hypotension due to alpha-1 blocking effects. They can cause alteration in mental status and rarely seizures due to sodium channel blockade in the brain, and due to some of the anticholinergic effects that we see with tricyclic antidepressants. CPR and cardiopulmonary resuscitation may be required in some patients. Hypotension should be managed with fluid resuscitation, and refractory shock states may require a vasopressor. Norepinephrine is recommended because this is essentially a distributive shock state that's produced by the alpha-1 blockade. All right, some examples of tricyclic antidepressants in common use include the following: amitriptyline, nortriptyline, imipramine, desipramine, and doxepine. There are many others, but they are less commonly prescribed and used, at least in the context of the United States. All right, and I would also say that if you are unfamiliar with dosing of some of the medications I am talking about, which you shouldn't, because sodium bicarbonate is a medication we've talked about multiple times and in some detail, but you can reference the dosing guidelines for those drugs within these clinical practice guidelines. Benzodiazepines are another common group of substances where we see overdoses. These medications tend to have a wide safety range. They usually have a fairly large therapeutic index, but can prove fatal, particularly when taken with other sedating medications such as alcohol. Polysubstance alcohol and benzodiazepine overdoses can be particularly problematic. Sedation and compromise of breathing are the most common results of these overdoses. The treatment is going to be primarily supportive here. This includes maintaining a patent airway, ensuring adequate ventilation, as well as oxygenation, and supporting blood pressure with the usual techniques. All right, the next group of medications I want to talk about are the so-called second-generation antidepressants. All right, so these are newer. And these include the SSRIs, or the selective serotonin reuptake inhibitors, and the SNRIs, or the selective norepinephrine reuptake inhibitors. These compose an incredibly large and somewhat diverse class of medications, including things like fluoxetine, sertraline, citalopram, escitalopram. The SNRIs include medications like duloxetine and venlafaxine. There, of course, are many others that are commonly used. Overdose with these classes of drugs generally have favorable outcomes with proper monitoring and supportive care. The SSRIs and the SNRIs are not as toxic as the first generation antidepressants like the MAOIs and the SSRIs. Signs and symptoms can include muscle spasms and clonus due to the possibility of an excitotoxicity and things like serotonin syndrome. So you'll see tremors, sweating, dilated pupils, tachycardia, tachypnea, confusion, agitation, and acute delirium. Treatment tends to largely be supportive. Maintaining a patent airway, ensuring adequate ventilation, oxygenation are important. Ketamine is not recommended in treating these patients or treating many patients with undifferentiated severe agitation or delirium due to some of the complex interactions that you can see with ketamine and these other agents. All right. Buproprion. Buproprion is Wellbutrin is a trade name for buproprion. Buproprion is a special case, and buproprion is it has some unique toxicities that are not as common with many of the other SSRIs and SNRIs. It's unique, and we'll talk about it. It is potentially more toxic than many of the SSRIs and the SNRIs, and it can also exhibit in large overdoses sodium channel blocker toxicity as well. Signs and symptoms can include tachycardia, drowsiness, agitation, hallucinations, vomiting, tremors, and in severe cases of overdose, seizures. Cardiac toxicity tends to be rare, but it has been reported, and you can get a widened QRS complex tachycardia in addition to or alongside the QT interval prolongation. And this can be associated with a variety of dysrhythmias such as ventricular tachycardia and its polymorphic variants. Hypotension can also occur. Seizures should be treated as any other seizure. Midazolam intramuscular is the treatment of choice. Hypotension should be treated with fluids, and if you suspect a severe sodium channel blockade toxicity, sodium bicarbonate may be considered as well. Moving on to the MAOIs, or the monoamine oxidase inhibitors. These are highly toxic medications, not in common use, but they are sometimes used in patients that have refractory mood disorders because they can be effective despite the numerous side effects and the narrow therapeutic index and the high risk for toxicities. The toxidrome is primarily adrenergic overstimulation. All right, so this is a sympathomimetic toxidrome that we tend to see with MAOI toxicity. Signs and symptoms are numerous and include things like altered mental status, agitation, sweating, tachycardia, vomiting, seizures, muscle rigidity and myoclonus, muscle spasms, elevated temperature, as well as coma and cardiorespiratory compromise or collapse in severe cases. Cardiac toxicity has been reported and can include a variety of arrhythmias, particularly tachydysrhythmias, and of course, hypertension. Treatment tends to largely be supportive, including managing the ABCs. Seizures should be managed as any other seizure with midazolam intramuscular. Expeditious transport should be obtained as there are a limited pharmacological options for managing MAOI toxicity in the pre-hospital setting. Also be aware that there are many different kinds of food interactions we see with monoamine oxidase inhibitors, particularly the tyramine containing foods, because this is a precursor amino acid for the sympathomimetic or sympathetic catecholamines that are produced in the body. And of course, the MAOIs block the monoamine oxidase enzyme, partially responsible for the metabolism and breakdown of monoamines like the catecholamines. All right. The next major group I want to talk about are the second generation, the so-called atypical antipsychotics. These have become much more commonly prescribed than the first generation antipsychotics. So the first generation antipsychotic medications include things like Haldol or haloperidol, Thorazine, and they are strongly anti-dopamine. They block dopamine pathways in both the central and peripheral nervous system, primarily the central nervous system, and they have classically been associated with lots of movement disorders like tardive dyskinesia, akathisia, dystonic reactions, and the like, which we've talked about in class can be managed with supportive care, possibly benzodiazepines for muscle rigidity, and even diphenhydramine to counteract some of the cholinergic effects. However, the second generation antipsychotics are much more commonly prescribed, and they have some different side effects profiles compared to their older first generation antipsychotics. So the second generation, or also known as the atypical antipsychotics, work more by blocking additional receptors such as serotonin, and some of them do also block dopamine receptors with varying degrees of efficacy. So let's talk about the atypical antipsychotics because they are becoming much more commonly encountered as opposed to the first generations or the typical antipsychotics. And these include a variety of medications like risperidone or risperidol, quetiapine, olanzapine, aripiprazole, and clozapine, as well as many other agents. Signs and symptoms are often complicated by multiple medications being ingested, and there are very often multiple medications prescribed in these particular patients because psychosis, particularly if it is associated with psychiatric issues, with thought disorders like schizoaffective disorder, schizophrenia, etc., these patients will often be on multiple medications. The signs and symptoms of overdose can include delirium, fever, tachycardia, blurred vision, red, dry skin due to the anticholinergic effects, agitation, hallucinations, alterations in speech. And the patient rarely recalls this event of in the immediate aftermath of before, during, and after the overdose or the peri-overdose event. Cardiac toxicity has been reported. As you might imagine, QT prolongation is common, and this can increase the risk for torsade de pointe. This has rarely been reported in the overdose of the atypical antipsychotics, however. Treatment tends to be largely supportive here, just like many of the other overdoses, and hypotension, if it occurs, should initially be managed with fluid challenge. The last agent I want to talk about is called lithium. Lithium has long been used as a mood stabilizer in bipolar disorder for over a century now. Like many of these other medications, it has a very narrow range of safety, a very narrow therapeutic index, and unintentional overdose is common. And unintentional overdose can occur even in people who are taking it as prescribed if they develop underlying physiological insults such as renal injury, acute kidney injuries, renal failure, dehydration, things like that can increase the risk for toxicity, even if they are taking the medication as prescribed. Long-term side effects and consequences of a lithium use are also fairly common as well. So signs and symptoms vary quite a bit and are often associated with the serum concentration of lithium in the blood, and often lithium levels are drawn in. We assess them to see how people are doing with their lithium if they are taking lithium for long periods of time, which people tend to take these mood stabilizing drugs for extended periods of time, if not throughout the duration of their life. These side effects can range from tremor, overactive reflexes. Tremor is actually very common. Fine tremors are very common with lithium, and tend to be a chronic manifestation of lithium use as well. Nystagmus, ataxia, and more severe signs and symptoms like confusion, agitation, acute delirium, tachycardia can occur, coma, seizures, fever, and even hypotension can occur. Cardiac toxicity is not as pronounced with lithium. It tends to be nonspecific and mild, all right? And treatment tends to be largely supportive in the pre-hospital context. Hypotension should be managed with initial fluid boluses, and if seizures occur, and they tend to be rare with lithium, but if they occur, our initial go-to pharmacological agent is going to be midazolam. All right, everyone, so that is your overview of the overdose considerations for psychiatric medications. If you have any questions over this, please reference these guidelines. There may be a quiz over them to ensure that you have reviewed these guidelines and you understand the changes. There really haven't been any changes. It's just we are putting more emphasis on this because we're seeing more of this in our community. And if you have any specific questions or you will wish to talk to me further on this, please get with me. We meet on January 17th for our first day of lecture, and I will try to address any questions you have about this then. All right, everyone, we'll see you in a couple weeks. Take care. Bye-bye.